Okay, I invite Dr. Ravish, who is our next speaker, who will be talking on planning my first multifocal lens.
Okay, good morning one and all. Thank you Zen for such an elaborate session on toric IOL. I'm Dr. RAVISH VAISHNAV. I'll be talking on planning my first multifocal IOL. As we know, routine phaco with monofocal IOL forms the bulk volume of our practice, but we need to shift gears and we need to move on to doing premium cases, provided we are prepared with the right technical skills, the right amount of knowledge, the correct instrumentation, and a proper planning for each and every case. Initially, I was not very sure as to how and when to start with the premium cases, as I didn't have the resources with me. I was new into private practice, and also I was not very confident as to how to go about with it. During my private, I had been visiting around at few of the places, so that helped me a lot. The idea was to learn from the senior doctors to see how they plan the surgeries, how they go about with the premium cases. Also, I would be able to cater to more patients, so I could get the premium clientele to my resources, and I could also make a name for myself. It's important to be in touch with the public, so I had some workshops and webinars where I could educate them about the options for cataract surgery and spectacle independence. I spoke about the different myths what they had. This goes without saying, you need to be seen on Facebook and Instagram these days. People do follow you, and then they can follow up in your OPDs also. I worked on my cataract surgical results. Right from the lower budget patients, I tried to aim for 6x6. Eventually, hoping that toric and multifocal would follow. I did OCCIs, LRIs, and obviously a good happy cataract patient would refer to you few or more cataract patients. So eventually many firsts did happen for me. A first topical case I did in my private practice, followed by a first toric case, which went off pretty well. A patient was happy. And very recently, almost 2 weeks back, I had my first phakic IOL case. But the case which did make me think a lot, plan a lot, was my first multifocal case. I would divide my case into 3 segments. The pre-operative one, which is the most important one, followed by the intraoperative, where you need to deliver the results, and the post-operative, where you have done your part, you could just pray for the best to happen. The pre-operative workup, it's very important to choose the right patient, and after you have chosen the right patient, the thorough counseling which has to be done following it. The pre-op examination, which has to be done just to rule out the contraindications, followed by the pre-operative scans to look at the eligibility for the multifocal lens. So the right patient depends on the following criteria. It has to age of the patient. Younger the patient, or faster the neuro adaptation, so better the result. Depends on the occupation, the hobbies what the patient has. Requirement of nighttime driving could be a factor which may not go in favor of multifocal, as it might cause glare halos to the patient, which would already happen in a multifocal lens. The psychological profile does matter a lot here. A patient who is overly critical with expectation of perfection usually are the most unsatisfied ones. And multifocal are best suited for patients who are highly motivated for spectacle independence and are ready to accept some amount of dysphotopsia which may follow after the surgery. So my patient did fit the bill perfectly. His age was 55. He was almost into retirement. Occasional desk job he had. He was a happy-go person, was into reading a lot. So I did go ahead with the surgery. Obviously, the counseling took major of my chair time. I spent the maximum time here. I cleared each and every doubt of his. I did explain the procedure thoroughly to him right from start to the end. Also the possibility of glare and halos or dysphotopsia happening post-surgery. I did tell him about the neuroadaptation, which may take from 3 months to 1 year. Then came to the pre-op examination. It was basically to rule out the contraindications. My patients luckily didn't have any of it. But if a patient has dry or MGD or anti-blepharitis, for that purpose, has to be treated well before the surgery. A corneal scar is a big no for multifocal. Pupil has to be looked into. A small myotic pupil would not give him a good near vision post-surgery. A larger pupil would cause glare halos. ZD cases are a total no for a multifocal lens. So likewise, glaucoma and macular disease patients which should not have a good contrast As always, the contrast already compromised in a multifocal lens, and amblyopia and strabismus patients also may not be the ideal ones. Then came the scans. Lenstar or a biometry, I would say, would be ideal for planning a multifocal lens. One, it helps you to get the right amount of cylinder in the cornea, and also the perfect or the precise accurate IOL power calculation can be done here. The cylinder has to be comparable with a topography. As you see here in my case, patient had a 0.4 cylinder in both topo and Lenstar. Also the ARK cylinder was comparable, it was around 0.25. The topo maps were in normal pattern. Need to screen the retina well. You have to be sure about the macula. Get a macular OCT done. My patient had a pretty decent foveal contour, so I went on to the next step, that is the surgery. It's basically planning the surgery right before actually doing it. So you need to plan the incisions and the rexus and the side ports. So the incision has to be on the axis always. It has to be a good firm incision. That is, it has to be away from the center so that it causes less of astigmatism. Side ports, I believe, have to be of adequate side as because a larger side port could cause some astigmatism. And very, very, very important is the rexus. It has to be circular, continuous, and a centered rexus to have a good IOL overlap. Okay, I come to my surgery here. So this was the patient. I start with the incision, which went on pretty fine. Followed by the side ports. It's important to form the AC well before starting the rexus. And the rexus part has to be very gradual. You have to be patient and slow. You can always take the pupillary margin as the guide. Use the microscope lights toward the centration. It has to be a circular, continuous, and a well-centered rexus. My patient had a softer grade of cataract. It was NS1 with a central PSC, gentle hydro dissection. The softer ones can be tricky at times. In this case, I could just get the nucleus emulsified without chopping it. I tried to get it out of the bag as much as possible, and I could eat it up in the AC itself. You need to do a thorough cortical cleanup, with no remnants of cortex. AC polishing would help to delay the capsular fibrosis and help in the better centration of the lens. Comes to the loading of the lens. The loading has to be precise, rightly done, slowly done in the cartridge, followed by a gentle and a gradual implantation into the bag. I'm sorry, I lost the centration of the video here. Now, very important is to remove the visco from the AC and also from behind the lens, because visco left behind the lens could cause decentration of the lens. You can use the microscope lights to center the lens, and once you're sure about the centration, you can hydrate the wounds. Always recheck before closing the patient, closing the eye, or even after removing the speculum, you could just check once again. So post-op day 1, this was the day where I could hardly sleep. The night before, I mean. The patient was happy, so was I. Patient had a decent vision, 6x6 blur with a good near vision. The lens was centered. I did dilate to confirm it. Then, I waited for a week for the eye to settle, for the astigmatism, the refraction to settle down. I planned the second eye surgery, which was pretty much similar in the parameters. And post the second eye surgery, that is 2 weeks later, this is what the patient had. He had a good 6x6 and 6 vision in both the eyes, and he was happy. I did explain him about the possibility of dysphotopsia and glares and halos. He was quite patient to hear about it, and it's been almost like now 6 months post-surgery. He's doing pretty fine. Thank you so much.